Good afternoon, everybody, and thank you for joining us for another one of our MAG educational seminars. And today we've got the very lovely Dr. Belinda Hibble with us. Belinda joined our MAG expert panel in October of last year. She is an accident and emergency physician. She's currently the Director of Emergency Services for Barwon Health. She's also a lecturer at Deakin University and has been consistently and actively involved in the education of young and upcoming physicians within her specialty. We're very proud to have Belinda on our expert panel. Sadly, medical negligence claims continue to be on the rise, and the initial triage and the accident and emergency area are often areas where these things can happen or can be alleged to happen. It's a very complex area, and it's the first port of call for people who engage with hospitals in the most instance. So we're very lucky to have her present today. I've seen the slides. It's going to be really interesting. May I ask that you please stay on mute throughout the presentation so that noise from your home or workplace doesn't interrupt the quality of the recording. There will be an opportunity for you to ask questions at the end of the session. The recording will be sent to you after the session. And if you have any other questions, you can always email me at any time and I will ask Dr. Belinda for her answers. So without further ado, thank you once again, Dr. Belinda Hibble, and over to you.
Thank you so much, Michelle. So I'll just share my slides if that. Here we go. All right. Can you see my slides there?
Yep, all good.
Fabulous. Thank you so much for having me. It's been a real pleasure to join Medico-Legal Assessments Group. I was really excited to give this talk because I feel very passionately about triage systems and about emergency care systems. And so it got me thinking quite a lot about all of the different potential times where there might be the potential for medical negligence claims or any issues that arise, particularly in that front of house space within emergency departments. We know that emergency departments across Australasia have been under significant demand certainly in that sort of post-COVID era, and so I'm sure it's no surprise that we are starting to see more issues in this space. So I'm going to just give you a little bit of an overview about the triage system and how it fits into the broader emergency care system for a patient and for a healthcare leader perspective, and then just talk about a few different examples of some of the issues that we see where things can potentially fall down a little bit or where there can be some breakdowns in communication or concern. And certainly, Michelle's spoken to my background. So I'm an experienced emergency physician and have been a director of a large emergency service for the last few years. So lots of experience involved in developing models of care, building new services, and considering the importance of triage as a safety mechanism within the system. So if we think a little bit about what triage is, it's originally just a little bit of history there from the triage word trier, meaning to sort. So it was first used back during the late 18th century as a wartime measure to try to prioritise who would receive care. And then in later wars, they started to consider the concept of mass casualty incidents with the aim of doing the greatest good for the greatest number of casualties. So how do you spread a finite resource to try to help as many people as you can? In healthcare today, we utilise emergency triage to try to reduce the amount of time patients take to access that emergency medical care to try and provide the best care that we can. So how do we pick out and prioritise, again, in a constrained system, to pick up the most high-risk people, the people that might benefit from immediate care the most versus the people that might be safe to wait a little bit longer? And so that kind of leads me on to why we perform triage in emergency departments well. As we know, we can have periods of really high demand in an emergency department. We don't have an appointment-based or a queuing-based system simply because we don't want somebody queuing with a broken arm in front of somebody that's having a heart attack. So how can we determine who gets cared for first in the most objective way possible? And how can we base that on patient safety? How can we make sure we provide healthcare equitably across the whole community, across everybody that might be able to come in, so that we can help people who might be more vulnerable seek care? And then how can we actually benchmark what we're doing? How can we compare ourselves within our ED, between our nursing staff, but comparing the demand or how sick people are across different shifts to reflect then what our staffing should be? And then how do we compare ourselves hospital A to hospital B? The triage system is used quite a lot as a marker of how many very sick people come to a particular department. So how big should it be? How many staff should be there? How much money should it receive? It's one of those important components that we use to determine that.
Code grey, emergency department, waiting room.
Apologies if, can you hear my overhead codes? I'm sorry about that. So what makes an effective triage system? So there's 4 key components for triage to be effective, given that we need to teach it to a large volume of staff and we need to try to make it consistent. So the utility, so the system needs to be really easy to understand and then to apply. So it's got to be really easy to teach to people so they can do it. It needs to be as valid as possible, as robust as possible. So it really needs to focus on urgency as opposed to severity or complexity. So you might have a really complicated broken ankle with your diabetes and your lung cancer and your high blood pressure and you're homeless and you can't speak English. But that is quite different to somebody that is having a heart attack right now. It's quite simple, but they're having a heart attack and their heart might stop. They might have a cardiac arrest before you get a chance to treat them. So we need to really focus on that urgency component. It needs to be really reliable. So as independent and objective as possible, what we want is for the same person to be triaged at a similar category, regardless of the triage nurse that applies that. So that we can be predictable for our patients and so that we can make sure we're picking the right patients in the queue. And it needs to be safe. So we need to be able to keep looking back at data. And we need to be able to then look at how we streamline people into appropriate care pathways based on that data. So it could be that we look at triage data and say, gee, people with chest pain were always given a category 3 in the triage system, but we know that 70% of those people have something very bad happen very quickly. So we need to adjust the triage categories so that all people with chest pain get a category 2, for example. So we need to be able to do that over time. And certainly that's what the Australasian Triage Scale has attempted to do. So the ATS, or the Australasian Triage Scale, was developed by the Australasian College for Emergency Medicine, and it's now the binationally agreed scale to be utilised in EDs across both of our countries. It's been adopted by the Commonwealth and state governments. It's applied in all of the public health service emergency departments. Urgency is reflected by the patient's clinical risk of imminent deterioration. What is the risk that something very bad might happen very quickly? It really focuses on prioritising sort of life and limb threats, as we call them. The strength of the ATS lies in how we evaluate the clinical descriptors, and I've placed them there. So this is a graph that comes out of the emergency triage education kit, which I've placed a reference to at the end of the presentation. It was originally published in 2007 and had an update in 2024 to look at just improving some areas over time to provide clearer direction after we learnt through that period of time about high risk groups for triage and what's changed. So as you can see, there are 6 categories, noting that category 6 is for patients who've unfortunately died before arrival to emergency. So we don't tend to discuss them further within the emergency context. But category 1 through 5, with 1 being the most urgent and 5 being less urgent. There is a lot of conjecture in the public narrative around GP type patients and low acuity or low triage category patients and whether or not they should present to emergency departments for care. It's a really vexed issue, and we won't go into it in detail today other than to say we have to remember that this is a very, very brief measurement that's performed or assessment that's performed right at the front door of an emergency department without going into the nuances of why someone is seeking care in the emergency department that day. So while you can have a very complex condition that requires hospital care because a general practitioner or specialists in the community can't provide that care for whatever reason, you might be a low triage category, but it's still really appropriate for you to present to an emergency department for care, and you will receive that care. It's just that there's other people that have been deemed to need more urgent care in front of you just at that moment. So it doesn't reflect the need to come into hospital, which is sometimes misconstrued. It's really saying, who do we have to run to and who will we see in turn? So category 1, immediately life-threatening, it is accepted that we need to treat these people immediately. And the performance target that has been set by the government is 100%. And it's generally built into emergency systems that automatically triggers because these patients are a very small cohort of patients that present needing active life support. They're needing CPR or they're needing somebody to breathe for them, or they're at imminent risk of death. It's usually only a couple of % of most emergency department presentations. Category 2 patients, imminently life-threatening or an important time critical treatments needed or very severe pain sits within there. Assessment and treatment ideally needs to be commenced within 10 minutes for this patient cohort. And you can see the performance targets down the right-hand side that drop off slowly for the lower acuity presentations. You can see their category 3 within 30 minutes, category 4 within 60, category 5 within 120 minutes. The interpretation of what assessment and treatment means and what care means is really different across the system and has been confounded somewhat by the different metrics that are used to benchmark emergency performance. When the triage system was first developed, emergencies departments were under different pressures. And the initial intention was, and they also were somewhat more medical centric in that the initial intention of those triage categories was to say, we expected a doctor to see you and provide treatment within 10 minutes or 30 minutes or 60 or 120 minutes. The narrative shifted over the subsequent sort of 5 to 10 years, particularly in the last few years, to we expect that you've had some assessment and treatment. Now, that might be by a registered nurse who's commenced a clinical pathway. That might be the provision of some symptom control, analgesia or antiemetics. It might be by commencing first aid, and then the clinician that sees you might happen subsequently during that patient journey. So that's an important sort of delineation that has changed over time. Recognizing that there are many complex, the system is far more complex, and there are many healthcare providers that can commence care for a patient while the decision making about why they've come and how to get them to the next place is sort of undertaken, and while queuing's happening. And a lot of it has been around queuing management. So when there are long queues, how can you commence symptom control? How can you commence a care pathway to get someone where they need to be to manage that queuing and the crowding that occurs right at the front and avoid bottlenecks? So triage basics. So as I mentioned, we expect our triage nurses to perform a clinical triage in approximately 2 to 3 minutes per patient. You can imagine in somebody who might be in pain, might be an elderly person, might have a hearing impairment, might be culturally or linguistically diverse, might be neurodiverse, that by the time you establish a rapport and introduce yourself, you could be near 3 minutes. And so it is an incredibly time pressured initial assessment. And it's really, really important that it is only considered the beginning of a care journey for a patient. And I'll speak to this a bit later, but what's really important about that fact is that it's important that the subsequent clinicians don't anchor too much to what the triage nurse said, because that triage nurse may have had 2 to 3 minutes with that patient. So you do need to keep an open mind as subsequent care providers get involved. And I'll have a bit of a chat about that shortly. So it's performed by a registered nurse with specific training, and that might be different depending on the health service. So big EDs will usually have a critical care trained registered nurse, so a nurse that's got a postgraduate certificate in critical care, and they'll often be able to perform triage, work in the resus area, or run the emergency department as a nurse in charge. But in smaller EDs, they may have had less formal or local sort of competency-based training to be able to perform triage. So it might differ a little bit. In some larger EDs, there is a shift to a model of a front of house team, which might look different in every service. And that's recognising the fact that because there is often a lot of crowding in the cubicle spaces in emergency departments with admitted patients waiting to go to wards, so access block, as people talk about, that crowding inside means that we're providing more care than we have previously in those waiting areas. And whereas 15 years ago with your tummy pain, you might have come to emergency, been triaged, been placed in a cubicle immediately, started your care, had everything happen, and then go home. People may, even in an efficient and timely running ED, have all of their care just in and out of an assessment chair in the waiting room, where they're brought in, someone takes history, gives them some medicine, gives them, does some blood tests, pops them back in the waiting room. So there's a lot more care happening in that front bit. And so therefore many big EDs have shifted their staffing models to load more people in the front. They may have a senior doctor, and that's a role certainly being piloted in many of the departments, whereby there's a senior clinician, usually an emergency physician, who can just pick out the high risk patients that they're worried about that don't necessarily fit in that triage system, or prescribe some additional analgesia, or order some imaging, or order some additional blood tests, or pick out the people that should definitely be admitted and go straight up to the ward quickly in an efficient way. And sometimes they can be a bit of a sounding board for the triage nurse too. So that can vary depending on the service. in the triage, these are all the things they've got to do in that couple of minutes. So they need to identify and manage any risks to themselves, the patients, and the environment. So has somebody come in bleeding all over the place? Do they have a weapon? What, is anybody at risk of harm? What are their first impressions of general appearance? Does this person look sick? And that's an incredible skill that's developed over years with many triage nurses, to pick the sick baby or pick the sick older person or pick the person that's just showing some signs that they're in severe pain, but they're not saying anything. We use a primary survey approach, so that ABC, airway, breathing, circulation, to inform that first initial part of triage, and then think about anything we need to do right now that'll make a big difference to that patient. So do they need thrombolysis? So a clot busting drug? Do they need an antidote? Have they been bitten by a snake or a spider in non-Victoria, or redbacks, but certainly big black spiders up the north coast? Do they need management of an acid burn to the eye, which needs irrigation really quickly, or it keeps doing damage? So they're thinking about that as well. And then early identification of any physiological abnormality can then inform where we need to go. So that's looking at heart rate, blood pressure, breathing rate. So this is a little bit of a table that looks at how we then use those vital signs to inform that triage category. How do we make that rapid assessment in our heads as a triage nurse while we're talking? So you'll often see the nurse talking to the patient, asking them how they're going, and simultaneously they're popping a peg on their finger, they're popping the blood pressure cuff on, and they're starting to record those observations. This is how you kind of delineate. Apologies, I don't have the Cat 2 bit there, sorry. But you look at whether someone's airway is blocked. They immediately go to a category 1 because they're about to have a cardiac arrest if that's the case. But then you look at their breathing. Are they breathing really hard or not really at all? And then you look at hemodynamics. So heart rate, blood pressure, pulse, or uncontrolled bleeding. And that will then sort of inform the triage category. Disability, GCS, so that's Glasgow Coma Scale. Generally, that just means, so GCS less than 9 translates to only responsive to pain or unresponsive. 9 to 12 is responsive to voice. They're waking up if you speak to them. And a GCS of over 12 means that they're able to respond to you. They might be slightly disoriented, but they're definitely conscious. So that's sort of used as well to then inform that triage category. And then the staff have to think about, what are some of the red flags I know in my mind for really bad things? So I know if someone falls from very, very high, it doesn't matter what they say, I'm pretty worried. So I might need to up triage them. If someone was thrown from a vehicle, that's bad. I need to up triage them. If someone's got lots of other comorbidities, maybe that what might make me more worried than someone that's usually quite fit and healthy. Babies, do they have a temperature? Have they had a big change in their feeding or their sleeping pattern? That makes us really worried. We do have to think about potential victims of violence and how we can speed up their care through the system so they don't leave before their care has been completed. Is this child at risk of neglect or harm? Has there been a risk of sexual assault? And then thinking about what happened before that person came to ED. What are some of the really concerning things that happen before someone comes to the emergency department? And then the other sort of things that get us really worried, envenomations, immersion. So drowning being if somebody dies from being immersed in water, immersion being if they haven't yet died. A rash, any effects of drugs or alcohol. So these are all the types of patients that we get quite worried about, and we try to prioritise for care because we know that this cohort of patients is at risk of really serious illness or serious injury. So before I get to where triage can go wrong, this just speaks a little bit to how patients get from triage to definitive care, because it's a way more complex system than it ever used to be. And in big services, it continues to grow in complexity as the whole broader health system grows significantly in complexity. That offers lots of opportunities for individualised patient care, but it makes it really tricky at times to educate staff who rotate through departments very heavily, and to help patients understand where they're going and what's happening next. And certainly in my role, one of the biggest things that we see when we deal with complaints or concerns about care is often that there wasn't necessarily a concern about the actual care that was provided. There is a lack of the patient's understanding about what on earth was going on, and they didn't feel like they were kept abreast of the issues, and that left them feeling disempowered and frustrated and worried that people were missing things, or that they just didn't know what was going on. That is just by far and away the most common issue that we see come up time and time again. So this describes why it's all a bit complicated. So we sometimes hear about patients coming before they come, but not always, by a GP or an ambulance service or another hospital. And so that's this pre-arrival or notification that happens. Then the patient arrives, they're triaged by that triage nurse, and a clerk comes to collect their details, match them up on the system, make sure they get all of that important identification step correct, identify next of kin. And then there's initiation of care that I talked about before. So that then at that point, maybe simultaneously with seeing a treating clinician, we start to think about early tests. Does this person fit into a particular pathway? Does this person need pain relief, need anti-vomit medicine, need fluids through the drip? Do they need an x-ray or another scan? Can I just see them and send them home? Can I just give them first aid advice and let them go home? Or do I need to stream them to be seen by any of our teams in the emergency department? So then we pick a place they need to go, and you will have heard about Fast Track as a place in many bigger departments where the walking wounded go. Ambulatory care area is another term that's used, and that's generally a lower acuity, faster turnover area for all the bruises, bumps, footy injuries, etc. You might be streamed to go to resus, the resuscitation area, because you're really crook. You might just need a cubicle where you can lie down because you can't walk, or you need monitoring that's quite urgent. You might need to go to the paediatric space because you're under 18. And you might need to go to be triaged to be seen by the mental health team. Many health services have tried to develop more nuanced pathways of care for people presenting with mental illness or psychological distress to emergency departments, recognising that they often have different needs to our patients who present with injuries or medical illness. And so there are more pathways available to that cohort of patients in many services. So the triage nurse might pick where you need to go, and they'll allocate that often on a computer system, which tells the doctors and the nurses in those areas who they need to then pick through, and whether that patient needs their care in a bed or in a chair, or in a bed but there's not one yet and they're in a queue for that bed. That happens too. From that point, ideally, there will be some patients that are admitted directly to a ward because actually they actually just need to go to the coronary care unit with their heart attack, or they need to go straight to theatre with their serious injury that needs treatment. Or they can go straight to a short stay unit bed, which has increased in number in many bigger health services. in most services, short stay unit beds are a hybrid emergency / ward environment designed for that 12 to 24-hour stay, bit more comfortable, bit more quiet, ward nursing ratios, but governed by the emergency department generally. So getting more frequent ward rounds than an inpatient ward, and used to caring for a more defined cohort of patients that we think just need a bit more work, a bit more care, but will get home. And so that's the rationale for the growth in short stay units. So patients might go directly there. And then at that point, we refer to any number of inpatient teams or community-based care pathways to either admit people to the wards, transfer them to another hospital, provide care in the short stay units, or discharge them straight home. So what I promised to talk to you about is where triage can go wrong. And the answer is in many different parts and in many different ways. But if we go through some of these examples that I was thinking through, unusual and rare presentations are really, really tricky. So if you present with crushing central chest pain and you're a 50-year-old man and you're pale and you're sweaty, you will get a really high triage category. Someone will look at you and think you need an ECG immediately, you're having a heart attack. And it is very, very likely that you will progress on that pathway really rapidly. If you are an 80-year-old female who may have darker skin, who may be having a painless heart attack, but you've just got some slight tingling in your fingers, and you present in the middle of a peak, there will be a cognitive bias there because that's an atypical presentation of AMI, acute myocardial infarction, and so it won't be at the forefront of people's minds. It doesn't fit in beautifully to the triage pathway, and so there is a risk that you might wait longer for care if there's higher demand in that system than someone who presented in a more typical way. So that is something that we see, and that can be a problem. If your vital signs are sort of reassuringly normal, that can be a bit of a trick for people. So if someone is on the antihypertensive group called beta blockers, their heart rate, or some calcium channel blockers, their heart rate will be quite low always. They can't mount a tachycardia. So if I get a serious bloodstream infection, my heart rate might be 180. If I'm really sick, their heart rate might be 70. And so people might think, oh, they're not that sick. Actually, it was the extra medication that you're on. And actually, the triage nurse didn't know you're on that medication because you forgot to bring your medications in and you can't remember what they are, or you don't have the list, or it came in a huge bag and there was a big queue. We know that elderly patients as well, they don't, and babies, funnily enough, can often, their physiology doesn't display as rapidly and early in some conditions. So for an older person, they can't get to a heart rate of 180. Their body doesn't let them do that. So they might be sitting at 98, 97 beats per minute, and they might be really sick. And they may be very stoic, and they may say nothing because they've grown up in a paternalistic system where you never ask questions and you never question the nurse, and you just sit quietly and you wait your turn and you assume that you mustn't be very sick because they haven't called for you, as opposed to somebody who's very, very aware of the healthcare system and knows how to advocate for themselves if they're a bit worried. So we see that problem. We also see people being reassured, funnily enough, with adults who can be quite tachycardic, but their blood pressure holds forever and ever and ever until it falls off a bit of a cliff. So sometimes there's under recognition of the severity of anaphylaxis in a young fit person, for example, because people keep saying, oh, their blood pressure's okay, their blood pressure's okay. But actually what tends to happen is their heart rate climbs and climbs and climbs, and their blood pressure's okay, and then they have a cardiac arrest. It happens quite quickly. So if you're not aware of those little pockets of people who don't fit the mold, there can be risk in a triage system. Complex presentations that don't fit into a clear pathway. So if you present and you are a fit and well person and you have a very straightforward problem like a heart attack, or if you very clearly are having a stroke, half of your body isn't working, it's very evident, there are some fabulous and very important clinical pathways that have been developed in many jurisdictions to support rapid care for you, to remove all the barriers. So a code stroke in some centres might mean the neurologists arrive, the CAT scan's cleared, you go through, somebody starts drawing up the thrombolysis, it's all happening. But if you present and actually you've got lots of comorbidities and this hand's not quite working, but it doesn't quite make sense with this one, and you've got a bit of tummy pain as well, and it's all not adding up, those patients take a lot longer to diagnose and try to figure out exactly what's going on. And I often think about the elderly patient with tummy pain because they can present with normal vital signs. They don't meet enough of a criteria to be a high triage category. They're very stoic. They sit there with their bit of tummy pain, and it could be a bit of indigestion, and it probably is, but it could be the early signs of a dying gut from a blood clot in a blood vessel, cutting off oxygen to the intestines, which is an emergency, but there's just nothing else showing you that that's what it could be. And it's only that in 1 out of every few hundred presentations. So how do you pick that patient out of the crowd? There is absolutely a risk of anchoring bias, and that increases with the number of clinicians that you have in any system. So the triage nurse sees somebody and says, they've got chest pain. I think they're having a heart attack. And then the doctor comes in and says, tell me about your chest pain today. And the patient just starts telling him about the chest pain, but doesn't then think to disclose the leg pain that they've been having as well, because they weren't asked about that. They were asked about the chest pain. And then the next person comes and says, well, we've proved that, you don't haven't had a heart attack, but it really looks like it's always been your heart. And they've been reading the notes of the people before them, and so they've continued down that path. And then every so often, someone comes in with a fresh set of eyes and goes, hang on a minute, this isn't all adding up. There's something not right here. Let's go back right to the very beginning. Tell me about the whole present. Why did you come in? What's going on? And then they say, well, actually, I flew overseas, and then my leg swelled up and puffed up, and then I started to get some chest pain. And the final clinician goes, oh, nobody thought about a PE. It is so easy in a busy system under pressure to pick up where the next person left off and just continue to march forward, because you've got many competing priorities, and you want it to be, there's a subconscious bias towards you wanting it to be that straightforward. And so we do a lot of teaching with all of our clinical staff about how you develop the spidey sense to go, something's not quite adding up. I have to pause. I have to give myself space. I have to listen again. Do I need to pull in a chair and sit down so that I feel more patient? Do I have to give someone my phone so it stops ringing so that I can listen and pay attention? Incredibly challenging, but a really significant thing that we see in some of these adverse incidents where people have all marched down the one path until it's either too late, or sometimes at a later point, someone's gone, nah, there's something not right here. It can be really challenging for culturally and linguistic diverse communities, patients and families, or people with communication difficulties. because they're time pressured, it's very rapid, and there may be a breakdown in communication there where we're not able to glean enough information to prioritise their care. So we have to think about how we can make that easier for people. And we've seen very prominent cases where we do think that that does create barriers for people to being able to escalate their care. It's really tricky to identify sensitive presentations. So to be able to come to a very public triage window in a queue 10 deep with 40 people behind you in the waiting room and say, I've been sexually assaulted, or say, I've got a problem with my vagina, or I'm bleeding, or I'm miscarrying. It is incredibly difficult. And so sometimes we actually find that the information given changes dramatically because they just needed to say whatever they needed to say to just get a spot in the queue, but they just didn't feel safe to say the next bit, which would have made us all a lot more alarmed. So that is something that we have to teach our staff. How can you sensitively extract information from people to inform your decision making? And the system can fail when overwhelmed. So the system wasn't designed to support consistent ongoing triage when there's a large volume of patients that have been waiting a long time. We frequently have conversations with staff about not second guessing triage. So what we see is a triage nurse on a very busy shift where there's tremendously long waits for care is at risk of up triaging somebody because they're so worried they'll take so long to be seen. But all we're doing is shuffling the deck chairs on the Titanic, to be crass, because all that will do is deprioritize the other people who objectively do need care as much as that person, even though it makes that triage nurse feel a bit less vulnerable because they're doing what they can to advocate for that patient. So what we need to do is to have systems within our departments that can manage that high demand in an effective way so that it doesn't affect the way the triage team are triaging, and so that we can help people escalate their care if there's been long waits or if things are changing. So issues for health services to grapple with. So these are some of the things that we talk about at a system level, and that we talk about within health services as well. And I do a lot of work with the Australasian College for Emergency Medicine in the how can we look at policies and procedures and guidance for health services about the types of quality standards to implement. So should triage nurses redirect patients to seek care elsewhere if they're felt to be inappropriate for the ED? And should this change due to changes in demand? So if you come requesting a script for your blood pressure medication, and you could have seen your general practitioner for that, should the triage nurse make that independent decision to say, actually, I don't think you should seek care here for that. You need to see your GP. There are varying perspectives on the extent of advice triage nurses should give patients, and I think it's changed and become a bit of a hot potato at times in some services because of the demand. Should triage nurses direct to the local urgent care centres? What is our duty of care if something bad happens to that person on the way? But realistically, if there's a tremendous wait for care at our end and we think it's a low acuity problem, isn't it just pragmatic to give people that objective advice? But should we change it due to changes in demand? There would be people that say, no, if it shouldn't matter how busy we are, if someone needs our care, they should get it. Well, yes, but they might have to wait a very long time. And is there a safer or more efficient way they can receive care? I don't have answers to many of these dot points, but these are the ongoing, really tricky questions that we have with our teams locally and at a system level to say, well, what are we going to tell health services? What do we think is right? It's really sensible if someone says, can I please have a Band-Aid for my cut finger, that we look at it and say, yeah, that's fine. Here's a Band-Aid, you can go. it probably is really, really reasonable to give people objective information about how long they'll wait. To say, no, I can't tell you how long you're going to have to wait, but you've been triaged and so you're just going to have to wait, I think is really unfair on patients, because they deserve enough information to make some decisions about their care. And so if you can objectively say, you are really welcome to seek care here. At the moment, there are more urgent patients. It may be some hours, but please let us know if something changes. Please come and check in with us. Then I think that really helps patients understand, right, well, I'm going to call and get the babysitter sorted, I'm going to make sure the dog's fed, and I'm going to ask someone to bring in my phone charger. But certainly saying you shouldn't be in the emergency department or this isn't an emergency problem is inflammatory, unhelpful, and often people haven't divulged their whole story. And so actually they're coming because of all of these other mitigating issues, or they couldn't seek care anywhere. So it's about trying to equip our triage nursing staff with that sense of, when is it okay to share some information, to provide some guidance, but to make people feel welcome, and to really, really encourage them that if they're waiting and they're worried or they deteriorate, to please escalate. And we know certainly in Victoria, there's a pilot around parental concern being considered as an additional vital sign that we record for children seeking care in hospitals and in emergency care. So in addition to objectively doing everything, checking the heart rate, checking the temperature, looking at the child, we say to the parents, are you worried? Are you more worried than you were before? And if they are worried and they're more worried than they were before, we need to consider what we're going to do about that. So to talk again about the patients that might leave prior to completion of their care, how can we support staff to have really pragmatic conversations about safety netting? So I think we previously were very concrete about patients who leave at own risk and patients who choose to stay. And then there was no room in the middle for patients that are really wanting to leave and are entitled to make that decision, but just need some safety net around that, where we can say, well, I really want you to stay, but if you're going to go home, can I give you these extra tips? Can I make you an appointment at the GP tomorrow? Can I give you this medication? Will you promise me you'll try and get this blood test? We have to be mature enough as a health system to encourage people to do that middle bit, because I think it's very paternalistic and unfair to say you either do everything we want and you participate passively and you sit there, or you're leaving at own risk. Right, here's a piece of paper, you sign it, your fault, you might die, that's on you. There's an in between there where we can say to people, I'm really worried because I think this might happen, but why don't you want to stay? Is it because we need the social worker to find out if they can get the dog into dog sitting? Is it because we need to call the relative to lock the house? Is it because we've given you no pain relief, or that bed's really uncomfy, or you're really cold? Is it because we don't have a culturally safe department, which is a big thing that EDs are looking at a lot across the system at the moment? So we need to teach all of our clinicians to be able to have really informed, pragmatic conversations that they document regarding what that safety netting looks like when a patient does choose to make a different decision in an imperfect system. And then what happens when people get sick? So we do know that patients, as we said earlier, wait in waiting rooms for longer periods of time at various steps of their care journey. How do they call for help? What does that look like? What happens? And how do the front of house team or the triage nurses, how do they call for help if they notice a problem? We function in an emergency department very different to inpatient areas. And so we need to have a really tailored approach to what that looks like. So health services should work hard to have a common escalation strategy that supports patients and carers advocating, and clinicians reporting a deterioration in care. So what does that look like? Who gets called? What's the language? What's the expected outcome? What are people meant to do? And then how do you advertise that for the patients so that they know what to do? So you need posters in your waiting rooms that are very clear and that have been shown to consumers to make sure they make sense and they're understood, that say, if you are worried, do this. If you are still worried, do this. And then you need to teach your staff to do what the poster says so that people get a predictable response and to close the loop. So it might be that a triage nurse re-triages somebody higher up the list because they're still waiting and something's happened. Or it might be that the senior doctor and the senior nurse have to have a huddle with that patient and their family. It's interesting, patient and carer escalation concerns are often quite different in emergency departments to the wards. The wards, you will have heard Ryan's rule in other states. Sorry, I'm Victorian, but Ryan's rule in Queensland, whereby often patients escalate their care because they fear that people have got the diagnosis wrong and you need to, or they're not being heard, and they need to have a system where they can get an independent third party in to try to remove that anchoring bias we talked about before, and try to sort of gain a bit of an independent second opinion. In emergency departments, that might happen very, very, very occasionally, particularly maybe in the short stay area. But 98% of our patient and carer escalation is around waiting. It's not around diagnostic uncertainty. So having the MET team arrive to provide an independent third-party opinion to someone that hasn't even been seen by the emergency doctors doesn't really work, because we don't need the MET team, but we need somebody, but we don't need a second opinion. We just need the first one. We just need to be able to reprioritise that person. So this is where services need to nuance it to what the problems are in their department, what they're seeing, what that risk looks like, and then how to tailor the approach to nuance to those particular issues. And it needs to be really clear for junior and rotating nursing and medical staff to know, if I'm really worried and I'm down in the low acuity area, how do I call for help to get a doctor and the senior nurse to come and help me look at this patient? So that all needs to be really clear and supported. How can we keep reprioritising in the context of fluctuating demand and resources? So if 15 ambulances all arrive at the same time, there's going to be a bit of a bottleneck from a period. How can we rapidly increase and decrease our various queues and our resources to be able to adapt to those changing needs? How can we make sure people are comfortable and feel like their care has been initiated while they're awaiting definitive care? So people are often very understanding when they see the staff running around everywhere that it might take a while for the doctor to take a history and provide them with their definitive care and let them go home. But if it's 8 degrees in the waiting room and they've been given no pain relief and no one's told them whether or not they're allowed to eat, and so they've now been fasting for 6 hours and no one can tell them how long it's going to be till the next stage of care, that's an awfully different experience to someone being able to have those basic needs met and being told, I'm terribly sorry, there's a delay. We'll get there as soon as we can. Are you worried about anything else? How can I make you comfortable? And then my final pitch is that we all need to continue to grapple with how our services can be more culturally safe and equitable for vulnerable communities. That includes First Nations communities, because in our greatest good for the greatest number of people approach that emergency departments are designed off, we really risk missing smaller, potentially marginalised communities, depending on where we work and the work we've done. So we need to keep that front of mind as a whole system. And Then I've just got the final, I'll just finish with the resource that people can refer to, which is the emergency triage education kit that I referred to earlier, which is a joint publication put out by the Commonwealth Government and the Australian Commission on Safety and Quality in Healthcare, and supported by the College of Emergency Nursing and Australasian College for Emergency Medicine. There's the link there. So I'll leave it there. I'm happy to answer any questions anybody's got, and very, very happy to take any questions off afterwards as well. Thanks so much, Michelle.
Belinda, that was really, really informative, and I thank you so much. In fact, I had 3 questions from people who were unable to attend today, but you answered each of them along the way. So I won't ask them. I'll just ask, does anyone who's attended here that's here have a question? If you want to pop yourself off mute and ask your question.
Hi, Kate, go for it.
Kate, we can't hear you. Okay, can't hear Kate. If anyone else has a question, please feel free.
Very happy for you to pop something in the chat or contact me offline.
Yeah, I do have one quick question, and that was, you spoke a lot about the cultural appropriateness of the care and of the environment and the mindfulness of that. And one of the questions that I did have was where a person appears to have a need for escalation of their place in the queue, so to speak, but they have a reason, like, for example, they are of a religious faith that can't have blood products, or for example, they are of a religious faith where it's inappropriate for a person of the opposite sex to handle them or deal with their body. How do the emergency services manage to do that appropriately?
Yeah, that's a fantastic question, Michelle. I think this is something that we try really hard to do within the communication, but I don't think is perfect all of the time. And so certainly in most services, there is absolutely an understanding that from a cultural perspective, if you have a need to be seen by a person who identifies as a particular gender, that we can document that, but that may cause some potential delays depending on the breakdown in workforce. I think that sometimes challenges are faced in smaller services where they don't quite have the number of the workforce that are so they might have a very small staff group that are all male, or a very small staff group that are all female, or vice versa. I think that we can still do more to make people feel safe enough to make these requests early on and feel brave enough to have the conversations about what we can and can't provide and not feel threatened by it. I think in a system that's under a lot of pressure, it can feel really threatening when people are making requests of us that are outside the norm, because we see it as another thing that we need to try to manage. But work that we try to do as leaders within these services is to help our staff feel brave enough and to prioritise the person enough and step outside of the system and into looking at that individual person and thinking, how can we actually just help you access care in the best way possible? And that will be by trying to meet those specific needs. So we'll communicate them often via the clinical record to try to encourage people to be able to meet that need. And from a blood transfusion issue, I think it's interesting. It's another thing that would potentially be a risk of being missed at the initial point of triage, because we would focus just on the hemodynamics in terms of just on the objective, what is the blood pressure, what is the heart rate? And so then when someone's seen by a clinician, it's at that point that people need to start teasing out, right, okay, so I would normally give you blood, but you have that's not appropriate in this setting. So what else am I going to do? And often that's at the point where there'll be a significant sort of escalation of, right, well, we need to try and stop this as soon as possible, and we need to try to figure out all the other things because we don't have blood transfusion available as a backstop.
Right. Look, this has been really, really very interesting, and I think really informative for our clients. I would love to keep chatting with you for a long time, but unfortunately we need to wrap it up. So I'm going to say to all of you, thank you for listening to the wonderful Dr. Belinda Hibble this afternoon. And thank you, Dr. Belinda. It's been really terrific. Everyone, as I said, you will get the recording within a day or so. And of course, you can watch any of our sessions on our YouTube channel. If you have any ideas for another specialist you'd like to speak to or a topic you'd like to discuss, please let me know. Thank you, everybody, and have a lovely rest of the day.
Thanks, Michelle.
Thanks so much.